if you'll take your seats, we'll go ahead and get started. This morning we are very privileged to have a guest speaker, Dr. Pat Walker. And Pat was in town this weekend for the Texas Surgical Society meeting, and we asked him if he would stay over and be our Grand Round speaker this morning. He graciously agreed. Pat is originally from Crockett, Texas. For those of you who don't know, it's north and a little bit east of Houston, a small town of about 6,000 people. He grew up there, went to college at SMU, went to medical school and did his residency at UTMB in Galveston. As a resident, took some time off for research, worked with Dr. Townsend and did some gastrointestinal hormone research there on some of their patients in the physiology lab. He then ultimately went back to Crockett to practice, where he has been what many people consider the model for a small-town private practice surgeon, being very involved in his community's healthcare system. He's on their board for their the hospital district and had a solo practice for many years, ultimately got a partner. In the process, he's taken an interest in things like snake bites and has even published a novel description for vascular access while working in a small town as a surgeon. In addition to that, he's been recognized for his contributions to the community and surgery at large by being asked to be a director of the American Board of Surgery, and has served as one of the board's directors for the past 6 years. And is the chair of the recertification exam for the American Board of Surgery. And as a result, we've asked him to come talk to us about the board and the maintenance of certification requirements for practicing surgeons. And so with that, I'll turn it over to Pat. And Pat, thank you very much for being here.
Thank you very much for allowing me to come here. I was here for a couple of months as a senior student in the summer of '80. It was an exciting time. I had a great experience with Dr. Alston McPhee, and they tried to straighten me out a little bit, gave me a lot of direction at Journal Club, and it was a great rotation. I really respected the clinical training you guys get here in San Antonio. So we're going to talk about three things today. One is the maintenance certification. That's going to be pretty boring to you students and residents because you guys don't even think about things like board certification. That's so far away from what you're doing today. But I think it's good for you to review this. And the point of maintenance certification is that you're going to be expected to continue to upgrade your knowledge skills, both in didactic techniques as well as skills, probably by the time you guys are out. Then I'm going to talk a little bit about the 80-hour work week and some problems and things that we've gotten to with that. And then in the last, I'm going to talk about changes that are going to occur down the line in surgical training and what we're going to expect out of that. So as I come here today, I'm speaking to you a lot as my position on the American Board of Surgery. Some of you guys probably don't even know how it's all sanctioned out, and I'm going to also talk only about allopathic medicine, not osteopathic, because I don't really have that much experience with that as such. The American Board of Surgery is one of 24 ABS boards. All of these as such. Now, you guys have heard of other boards like vascular, et cetera, and they all fall under one of these. For example, general surgery, or what we'd call general surgery, also covers things such as vascular, pediatric, and those sorts of subsets of surgery. Even has hand and the new end-of-life fellowship that's been put together. 11 of these are surgical boards. The ABS was founded in 1937. It's not the oldest surgical board. The colorectal guys will be quick to point out they were founded in 1934. It was to establish guidelines to protect the public and also to differentiate surgeons from family practitioners that were doing surgery. It was one of the first boards to institute recertification, and maintenance certification is kind of a continuum of that process. And so that's what the first half of this talk will be about. There are about 27,000 board-certified surgeons out, of which about 20,000 now already in this MOC process, which we're going to delineate to a great deal. This is the board. There's about 40 members of the board, public member, 3 at-large members, and they represent all the surgical societies from SAGES to Southern Surgical to the college, etc. All of us that are on the board have time-limited certificates and are either in or will be in MOC. Just before you think that the board's going to be the only person that tells you what to do. I want you to let you know that through your life, there are going to be plenty of people trying to structure your life and your practice. Some of them will have minimal control of you, maybe like the American Hospital Association, but even their actions will fall upon what you do as your practice. Some of them, like the medical board, you'll be getting letters from too often during your career. So this maintenance certification process started kind of coming about around 2000, and we're going to go back into how that came about more later. But the truth is, the Institute of Medicine about 2000 said that you guys are killing about 50 to 100,000 patients a year, and that wasn't the right thing to do. So the government got involved, and legislators got involved, and decided that they were going to start regulating healthcare. And we saw that in New York, as we'll talk about in a bit. And basically it came down to, are we going to regulate ourselves and try to enhance patient safety, or are we going to let the legislators do it? And that's where this MOC thing comes about. We'll talk about resident work hour stuff in a bit, but you already know plenty about that. So maintenance of certifications, a program, rather than just taking the 10-year recertification exam that we all did to recert, it now has a continuum of programs that we're going to delineate that goes so that throughout your 10-year recert period to ensure that you're maintaining your knowledge base. Every ABS diplomate, ABMS diplomate, whether you're in pediatrics or internal medicine, is an MOC. So don't just think that we selected surgeons to do this. So this is what surgeons in practice from the Congress a couple of weeks ago in Chicago. This just delineates what surgeons think about MOC. About 65% are in MOC. You can go through just getting some numbers here. So, about 2/3 think it's a good idea. I think we could put any program out there, and I'm surprised that 2/3 think it's a good idea. I would have thought about 2/3 would want to get rid of it immediately. And when you see the other facts, like 70% plan to recertify, you got to remember the guys at the college are a little bit older, and some of them don't need to recertify because they may not live 10 more years. So where did MOC come from? It started back in 98. The ABMS put together this task force to try to figure out, are we maintaining the best standards with just that 10-year quiz? And then they named the 6 physician competencies. You guys all probably saw that in some freshman ethics course. The 24-member boards get together and try to make MOC. Then in 2002, they established the 4 parts of MOC that we'll review, and then we began to require participation in 2005. We drug our feet in surgery as long as we could. So the 6 physician competencies, I'm sure you've seen these: medical knowledge, patient care and procedural skills, interpersonal communication skills, that's the part they put in for the ortho guys, professionalism, practice-based learning and improvement, systems-based practice. So these are considered what you're supposed to have to be a great physician. MOC has 4 parts. We're going to go through each of these and describe all of them in detail: professional standing, lifelong learning, cognitive expertise, and evaluation of performance in practice. And I'll describe to you what these are. When the average surgeon falls into MOC, they look at this and they go, how am I going to ever do that? And I'm going to say that the process is fairly simple. If you give us, the board, your address, your email address, we'll do most all of it for you. It's not like you have to participate in a great extent. So let's start with the professional standing. As such, that means you have a full and unrestricted medical license. That's kind of an obvious thing. You ought to have a license to be able to practice surgery. You ought to have hospital privilege. That's easy. And then professional references. And although these 3 are all automatically done by the college, by the board, they sometimes can be a little bit harder for us at the board level. Unrestricted medical license can be more difficult than you think sometimes. In the earlier days of bariatric surgery, a lot more physicians had leaks and maybe had some patient deaths or undue consequences, and those guys got turned into the medical board. And the medical board says, you're a good surgeon, you just got off into a new field, so you can go on about your business and practice surgery, but you can't do any bariatric surgery for 5 years or something like that. Well, that gave you a restricted license, which legally means that from our viewpoint, you couldn't have board certification. And we see many other ways where physicians' practices are restricted for one reason or the other, and we try to deal with those on a case-by-case basis and look and see if they're valid, because some of the medical boards, as you know, are fairly rabid right now. Hospital privileges sounds like an easy one as well, but we see more and more numbers of surgeons that don't even keep hospital privileges. They've got an outpatient breast practice, and they've got a partner that takes care of the inpatient stuff, and they may not keep privileges. So that's a problem for us. And then professional references. That's an email thing we send to the chair or the chief or sometimes the director of nurses. And sometimes the chair may be in a competing practice and not say some nice things about you. Again, we have to look at those as individual things. Lifelong learning and self-assessment, that's CME. And this is where it gets confusing, and I'm going to actually have a section on CME and tell you what CME is, because a lot of people don't know CME. We're in CME right now, and what kind is it, and what does this count for? So is CME valid? We don't know that. We think that there are several studies that say that if you do continuing medical education, you're a better physician, but it's easy to jump on that train and say, if I read a lot, I'm a great surgeon. That may not also always be true as well. So our CME requirements are not that onerous. 30 hours a year. I'm going to say this about 3 or 4 times in this lecture because nobody knows how much CME they get. 30 hours a year. Remember, the state's requiring you 24. So 30 hours a year, of which 20 has to have self-assessment. That means there's got to be some kind of exam or quiz at the end of it. This just delineates what I was telling you about, the 30 hours, which 20, 60 over 3 years, has to have self-assessment, and we'll go through that. Obviously, we prorate the hours if you just start. If you pass the quiz, that's a research exam. So remember, you're going to get out. You're going to go through your written exam and your oral examination, and then you're going to be board certified. You're going to, every 10 years, you have to retake a quiz that we call the recertification examination. If you pass that, you get 60 hours credit. So basically, you don't have to do any more self-assessment CME for 3 years after you take the quiz. So I'm just trying to show you how this is not going to be hard. It's going to be done for you. Here's some resources for CME. We'll break those down later, but there's plenty out there. You don't have to go find CME. The JACS has plenty of CME in it, 2 articles at the end of every journal that give you 4 hours a month. That would be 48 hours a year. Remember, you only have to have 20 self-assessment. ACS surgery, SAGES, and of course CSAP, VSAP, PSAP. Those are the pediatric vascular and of course general surgical things. I hope everybody has seen CSAP and has a couple of copies at home by the bedroom table. Cognitive expertise is the quiz. That's the recertification examination. Everybody gets afraid of that and gets worried. I'm going to show you some statistics in a minute showing you how easy it is. It's incredibly hard. It's going to be easy. It's going to be easier than any quiz you've taken if you study. And this last part, this evaluation of performance and practice, is an important part. That's the piece that's kind of coming together. What we want you to do is to look at your case and say, look, you know, my stroke rate with carotids is 40%. I'm probably off a little bit. And then figure out a way to fix it. Or, you know, 32% of my hernias get wound infections. I think I'm going to start washing my hands. Something like that. So there's going to be ways that you evaluate your performance, and I'm going to describe those. Part 4 resources. These are things that if you participate in these, you're already getting your performance evaluated. And obviously, the NSQIPs is the big one that steps out here because many hospitals are on NSQIPs. So they're already looking at your practice. And one of the things that's not come down a lot is all of you guys, at least the faculty, right now your performance is being evaluated by the hospital. But a lot of hospitals aren't sending that down the line to the physicians. They're not getting feedback. If you're going to make a change, you got to know you're doing bad. So if you're in trauma or vascular, transplant, or basically just about anything, your practice is already being looked at. And it's just one way to look at the MOC timeline. You get certified. Every 3 years, you kind of have to contact with the office so we can send out to confirm that you've got a license and get your references. Straightforward, and you've got to up your CME. If you do your CME through the college, you can automatically download that straight through the American College of Surgeons into the ABMS database. I want to make sure that some of the students and residents don't understand this, and many people in practice. The American College of Surgeons and the American Board of Surgery are 2 distinct entities. They're not any related other than almost all the surgeons in the college, but one is they have different purposes. The board is to certify surgeons and to provide the public with good health care, the college has a different role. And although they cross over in many positions, they're not the same and they aren't the same group. So you repeat this every 3 years until you get down to that 8th year, and you can take the recert exam in the 8th year, the recertification examination. And so you can take it in your 8th, 9th, and 10th year. Some of you should take it early, take it often, whatever it takes to pass the quiz. And this is just another way to look at those things, deleting out through professional standing, lifelong learning, the quiz, and then your evaluation of practice and how it lays out. And you go to the board's website at ABS Surgery and fiddle around if you want to look at more requirements. This just shows the 3-year reporting things. We'll find you in June. Keep your active email and or mailing address, and that'll give you through December to kind of get everything filled out every 3 years. We also have a repository now where you can keep your CME at the website. If you do CME, you can download it into the ABMS website, so it's already there. When you come up to your 3-year thing, you can show how you had your 90 hours. If you're in a fellowship, you only have to do parts 1 and 3. 1 is keep a license, basically, remember, and 3 is to cert exam. If you're double boarded, all you have to do is to do everything for one of your boards, or triple boarded, and then you have to take the quiz, though, for each board, and that's it. So if you're boarded in critical care, general and thoracic, you do the test for all 3 every 10 years, but you only have to do the other parts for one of those 3. If you fall off and drop out, this basically says that we're going to put you in the penalty box and make you do some extra CME and, of course, charge you more money. MOC, why should you do it? We're trying to give MOC more validity. And Blue Cross Blue Shield in the Northeast is now paying docs a little bit more if they do MOC. I think you'll see more and more insurance companies looking for board certification to get your compensation, as well as you'll be recognized as a doc that does continuing education. One of the big humps here is the bottom one. The Federation of State Medical Boards is about to institute an MOL process. That means that you're non-board certified, you're a family doc in Bernie, and you've never took boards. Maybe you just got out of med school and opened up your practice. They're going to have a process called MOL, Maintenance of Licensure, so you have to do CME and take quizzes as well. And so we're going to try to, or we're doing, is having the state medical boards recognize the MOL. I mean, MOC is MOL, so you won't have to do it back through the state to try to make it easier on you. All of us are tired of doing extra paperwork. So what are these benefits? It basically just says that you're a qualified surgeon. It says that you keep up with your continuing education, and hopefully in the end it'll help you not have to do redundant sorts of things for the states and insurance companies proving that you're competent. So I'm going to review CME and tell you what it is so that you'll kind of understand this. As I know a lot of people here, we're talking to a wide variety of audience, so I'm going over some different things, hopefully getting through some of you guys. So what is it? How much do you need, and where do you get it? Category 1, that's like what we're doing right now. It's really important that you differentiate between Category 1, which is this, and Category 1, which is self-assessment. If I gave you a 4-question quiz at the end of this and you answered 75% correctly, it'd be Category 1 with self-assessment. Otherwise, if you just walk out the door, you got Category 1. Remember, 30 hours a year, 20 of it has to have self-assessment. So enduring material, if you read a book, a journal, won't count for Category 1 unless you complete the self-assessment at the end. And then, of course, there's journal-based as well, but remember the self-assessment. So when you pick up Jack's, look at the 2 articles at the end that have the quiz, the little questions at the end, and fill those out. Or if you go to Medscape, do the Medscape articles with those. A lot of docs do Medscape. A lot of people on the board don't like it, but this is web-based stuff. A lot of people don't understand some other things of Category 1. If you notice that Dr. Jones has his 32% infection rate with his hernias, and then you define this problem, and then you say, Dr. Jones, you're going to start washing your hands, you've got a condition, and you come back in reassessment, that's actually Category 1 learning. Obviously, I've simplified this, but if you identify a problem, get a solution, and then reevaluate it, that's 20 hours of the Category 1 CME. Point of learning. This new patient comes in and they're on this new medicine called Xarelto. You don't know what it is. You hit the web and figure it out, and then you change their dosing of it so that you've intervened. That's a half an hour of Category 1. So there's many ways to get CME other than just sitting in a lecture hall. We even give people that complete a residency 20 hours credit. Maybe that's a little bit much for most residencies, but you get that. The test writing, 10 hours per activity. Test writing can be easy or hard. Manuscript review, publishing articles, poster presentations, and teaching. Like if I'm here for an hour today, I get 2 hours credit theoretically of Category 1. You get an advanced degree, or MPH and MS, you get 25 hours. And then, like I said before, if you complete the 10-year process, you get 60 hours of Category 1 self-assessment for that. So that puts you in pretty good shape as you research. Category 2 is just informal things. Teaching, unstructured internet stuff, reading, group discussions, medical writing like for the newspaper or the San Antonio Times or Light or whatever it is. Research time actually counts as Category 2. Not many people require Category 2 unless you're in an MA program trying to record some hours. Like I said, you get 60 hours of credit for taking the exam. So if I'm going to give you an example. If you did CSAP, which is 75 hours, I'll show you in a minute, and then the 2 years before that, and then you did the 60 hours of exam for the exam credit, you've covered about 5 or 6 years worth of your CME just by doing CSAP and taking the quiz. Now, the state boards may have requirements for your CME as well. There's 58 boards. Some states, like West Virginia, have a separate allopathic and osteopathic board, and they have requirements, and some of them are kind of strange. Some of them are things like HIV awareness, but some of them are child abuse that may not be relevant to you, and some of them are spousal abuse, which may be real relevant to you, as I'm sure you guys are all abused spouses as surgical surgeons. But you have to take CME in these topics in some states. It requires from 12 hours a year in Alabama up to many states 50 hours a year is the most common. Right now we have 24 hours a year in Texas plus an hour of ethics. And then this maintenance of licensure thing I mentioned a minute ago. How do you get it? You can get it through CSAP. That's 70 hours. ACS surgery. Virtually all of the major products now have some way to get some CME with credit as such. CSAP is I highly recommend as you get out and practice. If you're about to take the recertification exam, I find it hard to believe you can honestly walk through CSAP and flunk the quiz. So I recommend the product. It's produced by the college. I'm not really trying to sell all college products, but that's part of what they do with education. This is the recert exam for last year. If you're going to recertify in general surgery, you would have took the exam. It was given the last week in November, first week of December. It's a 2-week quiz, usually at a Pearson View Center. We moved it. You used to have to go to some place like Biloxi, and everybody'd meet there, or St. Louis, and take the quiz. And that was kind of fun because you get to meet everybody and have maybe a beer the night before or a couple of beers the night after. But now you go to Pearson View and you get to sit by somebody taking the cosmetology exam and truck driver exam. It's a little different thing, but it's much cheaper and more efficient than flying off somewhere to take the quiz. So the pass rate is 95.3%. The pass score is 60. You make 61, you pass. You make 59, you flunk. On the people that are recertifying, the pass rate's 98%. People that re-exam, that means if you take it and flunk it, the chance of you taking it and passing it the next time are about 50%. And if you let your certificate expire and come back, then the flunk rates are heavy. So don't let it expire. Take it early and get through it, and you'll be fine. This is who flunks it. I mean, if you're the critical care and colorectal guys are passing it 99% of the time. Pediatrics, vascular, thoracic, and of course it falls off as plastics people. They're not involved with GI surgery. So, I mean, this is a straightforward test. If it had a higher pass rate, it wouldn't be a valid exam. This is a problem here that we've examined. I want to go through this slide. It's really important. As you notice here, this is the bottom one is the top one is the qualifying exam. That's the written exam you'll take when you complete your residency. And the bottom is the oral examination. That's the oral exam that you'll take, which we call the certifying. If you pass the written, you take the oral. If you pass that, you're board certified. And then you fall in this MOC thing. As you can see, these fail rates are going up. And in fact, at some centers, it was almost 30%. We're concerned about this. We're concerned about residents failing an exam after 5 years or 6 years, or for some of you, 12 or 13 years of training. So we want to know what's wrong, and then I'm going to back off now, and I'm going to talk to you about a different topic. I want to tell you about the Libby Zine story, but most everybody here has heard it, the older people, but I think it's important you understand how we got to this work hour restriction. So on March the 4th, 1984, a woman named Libby Zine, she was an 18-year-old student at Bennington College in Vermont. She lived in New York City. Her father was a lawyer and wrote for the New York Times. Her mother was an editor. She was home for the spring break on a kind of a work-study program, and Libby had some problems. I mean, she was very depressed. She was on an MAO inhibitor called Nardil. She, in fact, was later found to have cocaine in her bloodstream at the time of her death. But nonetheless, she has these flu-like symptoms on a Sunday night. She's at home. Her parents are at a social gathering. They come in, and about 11 o'clock at night, take her over to the hospital. She's having some kind of seizure-type activities, some shaking-type movements, some low-grade fever, nausea, malaise. Nobody can really tell what's wrong with it. They think it's somewhat of a viral syndrome. They admit her. They call the family practitioner, a general internist actually, at home. He has her admitted to his service for hydration and observation. Nothing particularly could be found exactly wrong with her. I think they probably thought she was a little bit histrionic. Nonetheless, she's examined by an intern and seen by the second-year resident. She goes in the hospital, and that night she has more of the seizure activity, and they elect to treat her with some intravenous Demerol. She further reacts and has more seizures and is restrained. I guess you're kind of thinking this doesn't look too good. Girl comes in the hospital, and she has shakes, so you treat it with Demerol, and then you tie her down. Not going to play well in the press the next day. So about 6:30 in the morning, spikes the fever to 107 and arrests and dies. Not going to look good. So this is the process that happened with the death of this girl, and nobody really could define a cause of death. It was investigated numerous times. Nobody could find out about it. The parents were livid. They went to all the press, which they had access to in New York City, and it had big play. It was actually investigated by the New York Medical Board, who exonerated the intern and resident. However, the Board of Regents in New York overturned that and put them on double secret probation. And there was actually a criminal court. They were brought up for charges of murder. It was dismissed, but you can imagine you're an intern trying to do a good job. The next thing you know, you're in a court for murder. This is not a good deal. It goes along and along. The civil court, eventually there was a civil suit. It was settled for something like $275,000 between everybody, not a large sum. All the docs were cleared in 1991, so 15 years to get these guys cleared. Excuse me, 6, 7 years to get them cleared. So this intern and resident, that was a bad night for them. It turns out later on that she died of a serotonin release syndrome and collapsed of that, but that disease wasn't described when she came into the hospital, and nobody really knew, and it was probably almost unpreventable. It was an interaction with MAO inhibitors, which we used to use commonly for depression. Now we have much safer drugs that we can use for depression, but the MAO inhibitors are somewhat evil as far as side effects. So what happens? The New York Commission puts the thing called the Bell Commission. Bell was a family practitioner in an adjoining hospital there in New York City, and he decided the reason that she died was because the residents and interns were tired, and recommended this 80-hour work week with no shifts longer than 24 hours, and he had to have an attending physician on site. Well, we down here in Texas, we're hearing about all this. This was made national news, and we're going, that's what they do in New York. They'll never do something stupid like that in Texas. No way they're going to make the residents not be there all the time. That's where they're supposed to be. That's why they're residents. Well, sure enough, in 2003, the ACGME comes out with the duty hour requirements, and these are the original ones. I'm not going to spend a lot of time with that because I'm going to move on to a couple other topics. These were the original requirements. The 80-hour work week was instituted in 2003 nationally, and someplace like San Antonio it took effect around 2013. But and then last summer we re-revised these and made the intern have a 16-hour work day. That's made real good sense since the 24-hour day divvies up real nice into 16-hour segments. But there was a trade-off here. A lot of people understand why this 16-hour work week, including me. I think if a 25-year-old person can't work 24 hours, we're not in very good shape because you're going to have to do it in real life. On the other hand, the trade here to get this was that now the 4th and 5th years, the senior level residents can be at home on call every night. And that's what it's like in real life. When you go into practice, you're going to be on call every day, all day. Even when you're on vacation, believe it or not. And so we were trying to give a trade for the intern who's, I wouldn't say stupid, but is not really, needs to use every bit of brain for 12 hours, a big deal for them, in return for letting the senior residents transition into more of a, what it's like in real practice. And then they put together all these little small requirements, regulating PGY2s, et cetera. So you have to have a whole day off a week and not just once a year. Home call, basically can be on call every night. That's good. But if you come in, it counts toward 80 hours as such. Workload is supposed to be to what you're trained to do. That's kind of a, well, yeah, really, you're not supposed to be doing the aneurysms as an intern. And then we have this stratification of supervision that basically says that if you're an intern, you have to have level 1. That means somebody has to be holding your hand, or at least around, pretty close. I'm not going to go through all this. This also says that in the beginning here it says residents are supposed to know their limitations. And so that's a novel thought. And then I want to spend the time kind of closing up, so we've got a minute or two for questions about this GenSAC and what we're going to do in general surgery. And this General Surgery Advisory Committee was part of the board. There's about 5 or 6 of us on the American Board of Surgery, and it has this committee was begun this summer. And it has 2 purposes. One is we feel that the residents are voting that they're not ready to go out and go into practice at the completion of their standard residency. 85% are doing fellowships. So that's a vote. We need more training and we want more training. And then the other part of this is how do we preserve general surgery? For lots of reasons. General surgeons are so important in hospitals. You have to have them to make everything work. Even if you've done breast fellowships, critical care, you need to participate in the general surgical field. So what are we looking at? We want a better product out of medical school. We feel the med students, I know most of you guys spent your 4th year at med school out on the beach somewhere, maybe doing pediatric radiology in Galveston or in Hawaii doing surfing 101. But actually we're going to try to get some of the 4th year students to do rotations that will help them, prepare them for their residency. Those may include a month of critical care, a month of oncology. We're going to require certainly a surgical boot camp. It's going to be 4 weeks of intense surgical learning, including didactic lectures on things like hypotension, how to run a ventilator, practical knowledge. It'll have a lecture from the head nurse who'll be very, very rude and telling you what I need from a good doc, what I need from a good intern. Didactic components. It'll have a mock code section. I know you guys have a program here similar to this, and you may all already know about this. But this mock call, 14 times during your month, you'll get a call, sometimes in the middle of the night, from patients, from nurses, from other docs, explaining problems that you'll have to answer. You have a patient with hypotension. You have a patient that can't urinate. You have a patient that the wound's dehisced. Things like that, and you'll have to manage those appropriately. Then there's a section on hand skills, such as intracorporeal suturing laparoscopically, open skills, how to do a vertical mattress suture, and then a section on skills that we should all know as an intern, how to put it in an A-line, central line, chest tube, paracentesis, thoracentesis, tracheostomy, those sorts of things. So we're almost certainly going to require that. We're producing more flexibility in the residency. You now can do up to 12 months of your last 3 years in electives. The SCORE program, you guys know about already, the Surgical Council of Residency Education. We think that's standardizing the curriculum. You guys know about fundamentals of laparoscopic surgery. All residents have to do that. And now we have fundamentals of endoscopic surgery, where you'll all be certified as gastroenterologists that can do colonoscopy and gastroscopy and not have any trouble with credentialing. And we just approved that to be mandated into the programs. We approved it this summer, so it'll take a couple of years to get that up to SCORE. We're considering requiring a 6th year to be board certified. If you're doing a critical care fellowship, that would be your 6th year. We may count breast, I'm not sure. Yeah, we will. But we're also considering that 6th year maybe do a master, where you get a master's degree in surgery that kind of would be useful to you guys. Most everybody has the core of a general surgeon in their heart. And this master surgeon would recognize that with a degree, maybe a master of surgical science. And then we're still looking at this MLC program I spent time describing to you about, is CME really the right answer? Should we have you go down to a skills lab and show us you can do suturing, or should we just leave you alone and you go out and live in the hinterlands? I think that's enough for right now. I want to leave a couple of minutes for questions. I know we talked about a number of things, and I'll be glad to answer them now or later on during the day. Any questions?
Yeah, sure. Nice. I agree with just about everything you said. What bothers me, though, out of the 27,000 certified general surgeons, how many are there practicing general surgeons in the country? 60,000? Or how many are, I mean, what percentage are actually board certified? It's probably improved recently, but at one point in time, I think only half.
Well, I can't answer that completely. I think that you're seeing a move toward people keeping, despite the fact that MOC thing sounds onerous, it really doesn't end up being that way. I'm sure some of you guys are in MOC. It looks a little bit hard in the beginning, but the board does almost all of it for you. You've got just have to produce the documentation. You've done that, and the medical boards are actually calling you and wanting to show your documentation for your CME as well. So I can't tell you how many people are board certified. I think the number will go up as insurance companies and hospitals require board certification. As I said, we've got 27,000 active surgeons that are in general surgery. We don't call it general, we call it surgery. And 20,000 in MOC. But I've always heard there's around 60,000 docs in the country that do surgery.
The other is an observation. If we've all examined for the American Board of Surgery, and we have come across people that we know went through a very poor residency. No doubt about it. Not just because, we tried to trick them on a question. And I actually have hired an individual who came from one of these weak residencies who couldn't do a lap chole or an open inguinal hernia, despite being certified by the chairman and the laparoscopic chief. Are we looking at any of these programs? We have 240 some.
So this process, is not just a board process. It's also comes through the RRCs, that's residency review committees, through the ACGME, and they do more with certification of individual programs. If a program's fail rate goes up, the RRC's all over you. Keeping your program certified is probably as hard now as it ever has to been. We at the board depend upon that letter from the program director or from the chairman saying this guy's certified. There's no way we can go out and check the individual abilities of somebody to tie a knot. That said, that may be down the pike. And some of these things, 30 years ago, the board wasn't telling programs they've got to go do FLS and FES to prove that you can do a gastroscope. We just depend upon the program chair. But with these new programs that have milestones, you have to be able to move 6 widgets into the cup within so many seconds. Are those valid or not? Some people, like Barbara, thinks they're very valid. But they are actually milestones of accomplishment as far as that goes. Now, they give oral exams, and we see people that we know it's pretty tough. And so that's why one of the reasons the flunk rates are higher, whether it's because of lack of too much supervision, lack of work hours, or just, poor programs and poor training, or Generation X people that don't want to make the commitment to learn that. I can't give you all those answers. But at the end, the answer when we walk out of the room after giving the exam, an oral exam, is this doctor safe? So some of them we know they're pretty stupid. We just don't think that we think they're safe, and they'll get certified.